new watching and doesn't know who I am, I'm Susan Buttress. I'm the chair of the task force. And so now, and we do apologize, but we wanted to get everyone on and make sure we have a quorum, which I believe we do, but we will do roll call. I'll turn it over to Mary Claire.
All right, just let me know that you are here. Dr. Yolanda Barner.
Here.
Senator Hob Bryan. Senator Nicole Boyd. Dr. Susan Buttress.
Here.
Representative Sam Creekmore.
Here.
Miss Randy Carter. Dr. Daniel Edney. Dr. Tanya Fitz. Dr. Heather Hanna. Miss Biz Harris.
Here.
Ms. Ashton Hotard. Ms. Leslie Junkin.
Here.
Representative Kent McCarty. Representative Carl Oliver. Senator David Parker. Dr. Denise Elaine Powell.
Here.
Representative Rob Robertson. Senator Robin Robinson. Ms. Tracy Buchanan.
Here.
Dr. Casey Stratton Gackey.
Here.
Ms. Candace Taylor. Dr. Courtney Walker. And Dr. Tricia Wilson.
Here.
That's everyone. We have a quorum, Dr. Buttress. And I will go ahead and announce the advisors as well. Mr. Mitch Adcock.
Here.
Dr. Kenesha Bennett. Dr. LaShundia Carson. Dr. Candace Carter Stevens.
Here.
Dr. Katie Cassidy. Miss Georgia Graham.
Here.
Miss Sarah Myers.
Here.
Dr. Julie Parker. Dr. Kenya Elizabeth Wolf. And then we also have Dr. Annalyn Witt with MSDH. Dr. Tammy Brooks with MSDH.
Here.
And I think that's it.
Okay, thank you. And once again, I want to thank everyone for their dedication, all their work that they've done with this early intervention task force that I believe we all firmly believe is very important. I really appreciate your work. Okay, I'd like next for us to move to consideration for approval of the minutes of September 24th. Do I have a motion for approval? Okay, we have a motion from Dr. Fitz and a second.
Denise Powell, I second.
Dr. Powell, thank you. Second. So we don't need a vote on that. The other thing that I need to do is ask you all, the task force, permission to review and sign the meeting minutes from today's meeting, October the 29th. If that is okay with you, we need to have all the minutes signed and dated. So if you will give me permission to read over them and approve them and sign them and date them, I would appreciate it. I am told I need a motion to be able to do that.
Biz Harris motions for that.
Okay, Biz Harris, and I need a second.
I second. This is Yolanda Barner.
Okay, Doctor, got 2 seconds, Dr. Edney and Ms. So we appreciate that, and I promise I will read them carefully and make sure that they are reflected accurately as they really always are. Okay, I know everyone spent a lot of time in the last several days going over the report and the recommendations. And so we're going to have now presentations from the groups who worked so hard on this report. So the very first is General Operations and Management of First Steps. That's Dr. Julie Parker and Dr. Denise Powell. So I'll turn it over to you.
Thank you so much, Dr. Buttress. I am Julie Parker, and I served as the advisor for the training committee and recruitment, and I think all other things assigned. I think that's the way it was titled. So we have provided recommendations that we feel like are in line with what the task force talked about last year, but then also the new recommendations or additional recommendations from what the discussions have been for this year as well too. I did not prepare a PowerPoint and was remiss with that. I apologize. Really just thought I would give you context for what's in front of you. So let me try to do that. As we met as a group, we talked about all of the opportunities to really enhance competencies throughout the early intervention program here in our state. So we know, and we received an additional email yesterday from Dr. Witt confirming many of the recruitment efforts as well as training efforts that they have worked very, very intentionally about to enhance over this last year, especially since her tenure started. And so we're very pleased, and that report's going to be attached as well too. But to that, we recognize that adequate staffing is really essential for our early intervention program to be effective for all children and families in our state. And so we, in addition to being very pleased that we have more hires, we know that there are potential opportunities for even more individuals to come into the system, and we have some specific recommendations in regard to that. One is streamlining the hiring process. So we know that there have been unfortunate opportunities when applicants have gotten really bogged down with this current system and have not been approved in a very timely manner, therefore not allowing them to be out there to be the providers that we want them to have, highly trained, very highly qualified people. But we feel like that those issues with the process of onboarding have been addressed or are currently being addressed and not completely finished yet, but we know that reducing that time for hire is essential to getting more boots on the ground. We have more and more pre-service students coming out of our institutions of higher learning who are very well prepared to work within the context of our early intervention system. And so we look forward to that process continuing to be refined so that we can have a very robust workforce that serve children and families. We also know that the competency is a very important issue. If you look across the nation, we recognize that many states have very specific onboarding competency training for everyone who works within the context of their Part C program. That is one of our recommendations as well too. And the Part C program has been, again, working hard to implement what they currently have available to them. One is the early intervention competency modules, and we currently have 30 or so employees from Part C working in those modules right now. So we're excited about opportunities to continue that competency training. We know that with the training budget that our Part C program has, there are other things that we can do, and I'll talk a little bit about those collaboration efforts in just a few minutes. But making sure that we have a very intentional onboarding system that addresses competency training will be important as we move forward. And then also extending that training, there was a lot of discussion around really what providers need in regard to not just competency training, but actual training to get their job efficiently done. So opportunities to train on things like billing codes and treatment diagnoses and other Medicaid processes are essential. And so we're hopeful that in addition to the MIghty training system, which has certainly been effective for current providers, that some of these other training opportunities will be implemented within the context of either online training or trainings that are very accessible to providers coming into the system. With this training, what we hope will be improvement with the billing processes and the practices there. So the more our employees or the boots on the ground, the providers know how to bill and why to bill, then that billing process should actually streamline better. The other component, and I think this is going to be addressed in another section for today as well too, but is looking at opportunities for special instructors to become credentialed providers. Now they are licensed, and in many states that they do have a different title. And so I think that title is something that's being proposed as well, so that they could potentially have more reimbursement opportunity there. And then facilitating the recruitment and communication with providers that we currently have. One of the recommendations is to update the service provider directory. The directory, of course, can be a very fluid document because we have providers that do come and go throughout our system. But a provider directory would not only recognize the very hardworking providers that we do have in the state, but would also recruit other providers throughout the state as well too, because they know the quality of service that their colleagues are doing within our Part C system. So updating and keeping that directory very updated is an important component as we move forward. And then streamlining our collaboration with other partners, providing a collaboration for in-service training. There have been many years in the past. In fact, I served as the chair of several Mississippi Early Childhood Conferences over the years where we did have a specific training line for early intervention and early childhood special ed as a collaborator with the Mississippi Early Childhood Conference. We did a little bit of that this year. So Sarah Myers and I actually provided a session on early intervention to those providers, and those were mainly community-based early care and education providers, but also teachers within school districts and classrooms as well too. So we recognize that everyone within the context of serving young children, regardless of what their title is, needs training, and they need that cross-disciplinary training as well too, so that we all arrive at the same space and on the same page, making sure that we have the best outcomes for the children and families that we're serving. So we're hopeful that with some of the training dollars that our system has, potentially increasing those to some degree, would be helpful to do those cross-disciplinary collaborations to meet all the needs of persons working within the context of early intervention and early childhood within our state. Another really specific request is looking at children who come from our CPS, MD CPS services, looking at opportunities to have a very specific social and emotional screener. We've had some discussion around those children coming into our system. I don't have exact clarity yet about what they're eligible for. The thought is, and Dr. Buttress, please correct me if I'm wrong here, is that children under 3 who come into CPS automatically are referred for an assessment, and then from there determined if they're eligible or not. We do know that many children under 3, if they come from a family who significantly cannot care for them or has significant issues where they are removed from that family, those social and emotional constructs and foundations are so very important to assess as early as possible. And so adopting an evidence-based social and emotional screening tool really to better identify these social and emotional needs at the earliest stage is one of our recommendations as well too. We know that there are several tools out there that do a very good job at screening very young children with potential delays and or impacts on social and emotional development. So we're hopeful that that tool can be implemented within the context of our programming. And then additional recommendations are looking at additional training, and there are certainly opportunities to tap into models that are currently being used within the context of our state. The Project Echo model has been used not only with healthcare providers, but now it has transitioned into doing lots of training within the context of early childhood as well too. And so I know that one of our current ECHO projects through the Social Science Research Center at Mississippi State has actually been working with our Part C program to enhance training there. And so we're hopeful that opportunities for teleconsulting and teletraining like that will also be adopted within the context of our Part C program, because these models have demonstrated the efficacy for bringing together cross-disciplinary training, but also in a very timely and cost-less manner, so that providers can really be wherever they are throughout the state and still tap into high-quality evidence-based training. And then the last couple of recommendations we have are looking at a directory for natural environment. We recognize that that's one of the areas from when we submit our OSEP data that oftentimes we are not meeting our criteria there for natural environment. And even though natural environment seems to me like a fairly understandable kind of concept, what we recognize is that we have providers that come from different parts of our state to provide services in areas that they're not quite familiar with. And so having a directory of natural environments throughout our state that can direct providers to libraries where there are family programming for children that intervention could take place, or intervention play groups, other environments outside of the home and or the child care facility that would be considered under the definition of natural environment would be very helpful to providers on the ground, specifically if they're not currently from that area. And then the last recommendation that our committee put forth was really looking at how the State Interagency Coordinating Council can continue to assist our state office with these movements forward, how we can be a part of that. I serve on the ICC currently. We have several subgroups, and continuing with the leadership that we currently have, the ICC would be a very important body of professionals to make sure that we are providing that support to our state office to implement the recommendations that are being shared today, and then recommendations that they know that they want to address as we move forward. And that's all I have to present. I'll be happy to take questions.
Thank you, Dr. Parker. I think we'll hold questions until we have our general discussion after everyone presents, if that's okay with the membership. Okay. All right. Thank you again. Very well done. Okay, now we're going to the new implementation and service delivery model. Dr. Hannah?
Well, I just want to really thank Sarah Myers and Casey Stratton Gadke, because they're really the ones who put the meat on the bones, on the bones of this new model, and fleshed out a lot of great detail in the appendices. If you can take a look at those at some point, if you haven't already, in terms of technical guidance and recommendations for what an RFP could look like for a collaborative. I have, because she's such a wonderful technical expert, I have asked Sarah to speak and present the model to you. My main focus was on the process of developing it. And to that end, I will say that I feel like I'm really proud of the relationships that have been formed and how we've come together as a state around this issue. And I feel like this model really builds on the strengths that we have in our state. And it's going to be so important that we do continue to pay attention to communication and relationships, and also our national technical assistance, I think, in terms of implementing this model, should it be adopted. And so with that, I'll turn it over to you, Sarah.
Thank you, Dr. Hannah. I will share my screen so that everyone can see the draft, if that's okay, that Mary Claire and her team up here developed. Thank you so much for making that possible. for us. Let's see. Okay. Let's see if I can make that bigger. Can somebody tell me if they can see this okay?
We can see your screen, Sarah, but I'm not sure we're seeing what you want us to see.
Okay. Let me try again. Thank you, Casey. All right. There it is. I think I've grabbed it now.
Looks good.
Thank you. Okay. So thank you, Dr. Hannah, for introducing the new implementation model. As she shared, and you all are familiar with, and I'll just quickly recap where we have been. Our committee specifically was tasked with looking at implementation model, which, as you remember, is different from the service delivery model. So the implementation model is more, I would say, the meta view of early intervention, how our state is essentially going to help a family walk through the program from referral to intake to admittance and services, and then all the way out exiting the program and on to the next step. So that is what we are tasked with. We'll talk about the specifics, options that are available to us through evidence-based practices, which is more of the service delivery model options. So that's what Dr. Parker and Dr. Powell spoke to a little bit in overall quality and competency training for all of our providers. So we, as a committee, are staying more on the mechanics of how a family will get access to First Steps and how that will flow moving forward with this new proposed hybrid model. So again, as we shared at the last meeting, we are looking at developing a new option. So this diagram, I think, is really helpful to help us talk through how that could work for us as a state. So first, I'll start with, we met as a committee for a in-person session, just about the majority of a full day. We met, like I said, as a committee with the leadership at Department of Health and other committee members and other supporters across the state. We had a really robust conversation, looked at what other states that are using hybrid models are doing, and looked at what our state-specific discrepancies or needs are based on our state performance plan with feedback from OSEP. And then we, of course, looked at what our state resources are. So we had a really nice discussion, like I said, and we came to some consensus based off what we know those minimal federal indicators or requirements are for the state Part C program, okay? So the first step for any child and family is for that referral form to come to the central office. We're going to keep that referral form going to the central office. And as you can see, they're the primary, they have the primary responsibilities of managing every single case or family, so to speak. So that form, as you all know, lives on the Department of Health website, and they are moving forward, as you'll see later in this report, with some updates internally to streamline that process to make it online. Right now it's fillable, and then you have to fax it, call in, or mail a referral. But they're looking at ways to speed up that process and make that more easy for everyone. So that will still happen. The referral will come into central office, but what will change now is instead of there being one option, which is look at where the child resides and then direct that referral to go to that regional office and then those local programs to begin that intake process. What we will do is we will have an additional option here, and that will essentially allow other organizations that are going to be considered early intervention collectives through a competitive grant process to take over as that regional office, so to speak. So let's look at some of the differences here before we get into the nitty gritty of potentially what the EIC could do, okay? So there could be university programs, they could be a nonprofit, they could be a pediatric therapy clinic, a school district even, or maybe even a local program under First Steps. So they could be lots of different entities that already have shown success in providing services to children and families under this Part C program, right? Or have the potential to do so based on their history. So the Department of Health will have to develop that RFP process for these folks to apply. That'll be, like we said, competitive, and that will go out statewide. But as you can see, and you're looking at the two options here, what we're going to do is essentially allow for these folks to look at their capacity to provide direct to all the services and meet all the federal indicators, just like the regional office would for Part C services, meaning that they have to be able to screen, assess, evaluate themselves, determine eligibility themselves, house service coordination within them to develop the IFSP and manage the plan for the family and provide the services directly in those families' natural environment. So there will be a requirement that these EICs must provide 90% of their services in the natural environment. The other difference that you're going to see between option 1 and option 2 is with the EICs, we are making it a requirement that they employ providers. So the majority of our providers right now with First Steps are contracted. So what we're looking for here is entities that have multiple disciplines. So they have speech pathology, occupational therapy, or maybe a special instruction and physical therapy. So they have a few different disciplines of EI providers, and they are employed primarily with the program. And what this does is it obviously allows for these folks to work together to collaborate on the multitude of developmental needs that these young children may have, okay? So that's one difference between option 1 and option 2. And then the last thing that you'll see is that the EICs, we're going to lean on them to provide training and consultation, because again, these are spaces or entities that will have folks who will specialize in specific things, like let's say teachers of the visually impaired, for instance, and not all parts of the state and not other areas of the state may have access to somebody that has that skill set. So as Dr. Parker shared earlier, we've got options to our avail that will allow for providers to reach out if they know who's in network with early intervention with an EIC, and they know that they specialize in something that a family they're working with needs, who lives outside of the EIC region, they can reach out and get a consult for that family, right? Or they can reach out just themselves as a professional from provider to provider and say, hey, I need some support. I need some resources for this family. So that's one of the responsibilities that we have tasked the EICs with providing. The way they move through the program, you'll hear that, we have looked at improvements on both ends for the current First Steps program with option 1. And we'll also look at the same with option 2 with EICs. But what our efforts here would be to essentially try to address some of the inequities that are already occurring and not make that even a wider gap by, again, offering that training and access to specialists who may only live in a certain high population or high density area of the state, and make sure that those folks can support some of those desert areas. And then obviously, as this process continues to roll out, should we get funding, should the Department of Health get funding and be able to produce these competitive grants, and we move forward, then we would hope that as the years go on, more folks would look and be able to see themselves in early intervention, more provider groups, and we would have more EICs across the state that would partner with Department of Health to help provide these services and help fill in some of those gaps. So I believe that gives everyone the basis that we need to move forward with the meeting. I don't want to take up too much time with details, but I'll stop my screen. Dr. Hannah, was there anything else that needed to be added?
No, I think that's great. Thank you, Sarah.
Thank you so much. We really appreciate this and always love a graph like this. I think it makes that visual aid is great and very helpful. All right. And finally, we'll move to the improved billing and reimbursement model.
All right, okay, can you guys see on,
Dr. Fitz, I'm sorry, I didn't say your name, Dr.
Okay.
Tanya Fitz.
I'm Dr. Tanya Fitz, and then we're here. Can everyone kind of see my little slides? Okay. I did some slides because I need help when I give a talk. The overview of what our group was charged with was assessing and assisting and implementing new billing procedures to improve reimbursement process. That's been a main complaint that deters people from enrolling in our early intervention program. And then initially, based on our work last year, implementation and looking at a pay and chase type model, and what kind of bank would we need and would it be sustainable? And after much discussion and review, we determined that the pay and chase model would not really work. And so we pivoted to looking at what would our early intervention collectives really need to make going. And I really want to thank our task force members, Biz Harris, Representative Creekmore, Representative Carl Oliver, Senator Robinson, Ms. Buchanan at Mississippi Medicaid, Dr. Edney, Dr. Buttress were our members, and our task force advisors were Casey Cassidy, Candace Charter Stevens, and Mitch Adcock. And I want to give a special shout out to Mitch because he really helped us through this side of the process. And a shout out to Dr. Annalyn Witt, Dr. Tammy Brooks, and Ashley Wolf, and then Mandy Smith, and a real shout out to Mary Claire and Emily for all of their assistance. And so we kind of started looking when we were looking at all of this, if we used our goal of our 3.8 to 4%, there would be approximately 3,000 to 4,000 kids served. And the amount of money to have a bank to just pay that out and chase it was just outside of our reach. And then we looked at the collective model overview, and Dr. Parker and Sarah have done such a wonderful job talking about it. I'm going to skip forward a little bit, but we did look at their needs, and the evaluation teams, a treatment team, some service coordination, a billing department, training funds, and administrative funds. But some of the things that we found when we were looking at that were the current models have not been billing in the Mississippi State and USM groups have not been billing at all. And those people to be brought into an early intervention collective where they've been doing amazing work, we need on the front end, and I don't have my pretty little picture, but before we can even start talking about billing Medicaid for the services, they have to be credentialed. That's one thing. And they also have to have contracts, and contracts not only with regular Medicaid, but every Medicaid managed care organization. Also, they need to be credentialed and contracted with all of our private payers as well. And that's a major headache if you've ever tried to deal with that. And we felt like that was a main need that needed to be addressed for the implementation of this new model to be successful. So I'm going to try to go through our, it is part of our thing, so I put it up here so we can read it. That MSDH should determine the types and services rendered and how those services are reimbursed. We did find out as part of our discovery process that the early intervention evaluation, there's not a code for that covers that initial evaluation team going in, and all of that is being paid for out of the payer of last resort funds. And that needs to be improved. Develop and provide mandatory training and guidance for the First Step staff, EIC staff, service providers to address the billing process. This is in addition to how they're going to be actually doing wonderful treatment processes. This is the billing process, including the billable codes, services, procedures, and claims processing. That is in addition to, are we doing the speech therapy, occupational therapy, and wraparound services correctly? And to develop a timeline for communication with the early intervention collectives, service providers, and regarding any updates to the billing process. And to develop and provide access to credentialing, contracting, and claims processing for all service providers without capacity, or whether it is cost prohibitive by either internally developing a unit to handle these or contracting this out to a third-party administrator. There are lots of billing companies that do specialize in the credentialing, contracting, and actual billing process. If you look on Appendix E in our draft, there's just like a simplified, this is kind of how a biller goes. But before we do all that, we have to have a contract that we send the billing to. Some of the early intervention collaboratives are going to need access to electronic health records if they're doing physical therapy, occupational therapy, things that, and services that provide CPT codes. And we would encourage that the health department also supply and sustain those people and in some sort of advice or access to the Epic EHR that is currently used at the health department. To develop a business model to study and address the cost and revenue generated with the associated staffing, procedure change, operations, and develop in coordination and communication, the billing structure to address the billing code discrepancies, negotiating with third-party payers, and develop a claims payment process. Other states use kind of undefined or open CPT codes that some of them start with the T. Some of them also use different modifiers to identify within that system that this is an early intervention child. To have developed staffing models to have more frequent processing, a payer of last resort funding request. Currently, it's done monthly on the 15th. And if you don't submit yourself by the 15th, and then they have 45 days after that to pay it, this is a problem if you're trying to make your payroll as a small business and pay your rent and your light bill and the people that work for you. And then present its business plan and financial need information to the State Board of Health for its review, and a legislature, the peer committee, and the SIC subcommittee. And direct and staff providers to bill Medicaid for Medicaid covered children for services, and encourage parents to utilize their private insurance with the assurance that MSDH will cover deductibles and co-pays per the program policy. Then it's a lot. I'm sorry, guys. There's going to be requested data information and oversight from the SIC subcommittee responsible for providing program oversight, and on an ongoing basis, review, communicate, and coordinate with the Division of Medicaid and private insurance carriers to negotiate covered EI services on behalf of service providers, including identifying reimbursable codes, bundling those service codes, I've mentioned that earlier, reimbursement rates, and making sure that the allowed place of service, this is the most important because currently this is a major roadblock, that the allowed place of service locations include the child's natural environment as mandated by federal guidelines. Currently, things are paid for in an office setting and not in the home-based setting. So we would like to have natural service environment be made allowable. And work with the Mississippi Department of Insurance and DOM to simplify the prior authorization process. This is another main complaint that we get from our providers, is that each different Medicaid MCO has a different process for prior authorizations and for length of the approval of the prior authorization. So someone who is in the early intervention, we are redoing their evaluations. They have wonderful documentation. We don't need to necessarily force our early intervention collectives to do a bunch of paperwork that's more people, that's higher cost overall. And then recommend that the MSDH and DOM present amendments to the Medicaid technical bill for early intervention services to the House and Senate Medicaid committees, and recommend advocating for universal credentialing through amendments for the Medicaid technical bill and credentialing as distinguished from contracting with the managed care organizations and credentialing as well, and present recommended any other necessary legislative changes to the legislature, including changes to the billing codes and the prior authorization process. And once it has effectively updated the billing process, study and perform a business analysis on other financial models, including pay and chase. Like once we've got this settled and can we fund our own pay and chase, to determine if it's economical and include the necessary state funding that it would need to implement such a model. But we have to get all of these other things in line first. And I feel like it might be moving a big mountain, but that's that. We also should utilize the central billing unit to provide credentialing, contracting, and service. If the early intervention collective should regularly communicate billing issues with the MSDH to the central office. Like, you know, if all of a sudden Magnolia MCO starts sending you a bunch of denials for XYZ, we need to know that as soon as you get them, not 6 weeks later. Adhere to the MSDH policies, such as pursuing other funding sources before utilizing payment of last resort funds. Assist and provide data as necessary to support the SIC subcommittee in carrying out its duties. And once a standard set of billing codes are established, ensure they are utilized for the EI services.
Thank you, Dr. Fitz. There's a lot, right? Mitch, I know you were, Adcock, I know you were very much involved in this. Do you have any comments you want to add?
No, very good job.
Thought it was a great summary. So before we get to our open discussion, I wanted to give the State Department of Health an opportunity to speak. And I know Dr. Edney just walked out on a phone call. Of course he did. Would you like to take this on, Dr. Witt? I know you've been very involved.
Okay, so take which part on? As I'm thrilled to be here at the table, and I appreciate all the hard work that's gone into this, as well as all the behind the scenes work that's gone into all of this. And I look forward to continuing it.
Yeah, I will have to say, in deference to Dr. Witt and Dr. Edney, that they really have been working very closely with us and listening to every single thing that we've discussed. And so I want you to know that we really appreciate it. And I know that there have been a lot of changes. And in fact, in addition to the report that you all read, I'm not sure if you had the opportunity to read the additions that Dr. Witt had that they have made as far as improvements that, you note will be in the appendix, since
Mhm.
it would have changed too many page numbers and charts if we had added them in the body of the document, but we'll make sure that it's clearly.
And if I may, Dr. Buttress, I'd like to just recognize Tracy Buchanan and Robin Walker at Medicaid. We have had some very hopeful discussions already about coding and the needs. And they are currently waiting on me to send them an estimated budget report of what that would look like to open some codes. And so I just wanted to go ahead and thank their partnership in that, because we have started some of those discussions right along the lines of what Dr. Fitz has been recommending today.
Great, thank you for that. And when Dr. Edney comes in, if he has any additional comments, just let us know. We certainly want to give him that opportunity. I will say that I think our task force has realized that no matter, we tried to separate it into the three big sections, and there's so much crossover because delivery model can't work if you don't have the training in place, if you don't have the evaluation, and if you don't have the billing. And so no matter what, this cannot be done in any kind of siloed fashion. It has to all work or it won't work. And so with that, I'd like to just open this up for any discussion, any questions, any reiteration that you want to make. We have a good 30 minutes that we allowed for this, and I really do want to make sure we hear from everyone who might have a comment. So I'll pause for a minute, and if you are online, please just unmute and say you have a comment, if you will, because I can't see everyone very well.
Dr. Buttress.
Yes.
May I interject just one comment? As many of you probably know, we are in the middle of our federal monitoring site visit this week. And one of the things that we have been discussing the last day and a half is current monitoring of our local early intervention programs, which of course puts me towards future monitoring of our local early intervention programs, which will have to be done by the lead agency per the federal statute. So I would like to go ahead and put out a request to the state ICC to consider that as a committee that will also continue a lot of this work as well. And that may not be the right fit, but like I said, I just wanted to go ahead and put that as a need within the next 6 months. And that does affect like the competitive process that will have to go into that whole document, and as well as any external evaluations that our local collectives may want to do on their own.
Thank you for that. I do understand that there has been some reorganization, perhaps changes in the ICC also. Is that correct?
We were, so I don't want to lie to you about the dates, but I believe it was sometime in June. Dr. Edney and Jim Craig and the governor's office appoints who is on the state ICC. And just recently, and I don't have an exhaustive list in front of me, but just recently we did elect our executive committee. I don't have the notes in front of me, I apologize, but Leslie Junkin is our chair. And we have 3 parent representatives, if I remember correctly, and Sarah Myers as our vice chair. So that's our executive committee. I just wrote down a note that I've got to schedule a meeting with them. And we will be utilizing our National Technical Assistance Provider, ECTA, to do state ICC refresh onboarding and training of how a state ICC needs to function, and serve as the primary advisory committee to the early intervention programs according to federal statute.
Thank you.
Sure. And we can always put a list of who's been appointed to if we need it. I can get that to you. I just don't have it in front of me.
Sure. It's fine. Thank you. Any other questions? Yes, I see one over here.
I am new to this whole thing, so I was looking back over the last year's document just to kind of see what all we needed. And this might be something that can't, but I was also talking to my local senator and I brought last year's and I was just kind of talking about what we were saying. And he was very interested in this section that talked about the money, about the level of funding. And I didn't know if we wanted to include anything about that again this time around. Specifically, you know, what the other states are doing and maybe what might be working for them and how they may have done these similar models. I just wanted to add that.
Well, I'll just comment and then I'd love to have any additional comments. So we do refer back to our original task force from 2023. So anything that we did last year, we hope is linked and will be looked at. We didn't want to have another exceedingly long report, but something that was focusing on exactly our recommendations right now. Senator Boyd, did you have any comments on that? Oh, you got it.
First of all, thank you for going ahead and talking to your local senators and representatives about that. That is incredible that you're going ahead and do that. I hope everybody will do that. But at some point, it might be great if everybody else is going to do that. We kind of get a talking sheet for everybody to make sure we're portraying the same information and using a talking point sheet off that. But that's something we can do at a later date, but it just occurred to me that might be really helpful for us to internally do that, just a few of us. So, but thank you, because I hope everybody, after we get through with this, will go share this with your local senator and representative. Thanks. So.
I don't know. I hope everybody heard that, but I think that's an excellent idea to have a sheet of talking points as we now go and promote our recommendations to our legislators so that they can, in case they don't have an opportunity to read the whole document, that we have some very clear talking points. Now, you have seen a summary, the summary sheet that Mary Claire and Emily did so well as far as outlining the general bullet points. And it's a 2-page document, but typically I know in the past, many times I don't have the opportunity to talk in 2-page sessions. So maybe to have a few bullet points. Now, one that you're bringing up, Ashley, is that I think, and it's a very good point, how many dollars do we need? What are we asking for? And the bottom line is we are hoping that the health department can come up with a summation of that. We know this will likely need to be a gradual implementation and not jump in with both feet with every bit of everything that we think should be done. That obviously doesn't typically happen, but we know that the early intervention program has been vastly underfunded and underutilized, not just underfunded, but underutilized due to the lack, perhaps, of the easy to access services and the difficulty in which we've outlined and the many opportunities. So with that said, that is something that as we go and have those bullet points that I agree with Senator Boyd, perhaps we need to work very hard on that, 5 maybe at the most bullet points that we want to present. But with what kind of dollar are we asking for in the near future? Yeah.
Thank you, Dr. Buttress. I want to make sure that we keep things in perspective. The core appropriation from the state for the Department of Health, the money that we're appropriated to run the agency is about 25 million. And then we have our public health programs, which include early intervention, but all of our programs is about another 20 million total. That's it. So when you look at state support for public health in Mississippi, it's quite low. It's one of the reasons why we didn't make the state auditors list. We don't get enough state money to worry about. So there are two requests. There's the model build, and then there's the sustainable funding to make all this work. And this is what needs to be funded. But it's going to be somewhere approaching 19 million to do it right. For us to be in line with, say, Alabama, we need at least 10 million a year. And right now we're less than 4, with 2 million of that being directed to providers. So there's not a lot there to work with. And so I think we need to have a reasonable ask, because when you ask for too much, you tend not to get anything. But if we don't ask for enough, we're not going to get more than what we asked for. So a comfortable number to make this work would be 19 million. Do I think we're going to get 19 million? It would blow my socks off to imagine such a thing. To imagine that we're going to get an early intervention appropriation that matches the agency's overall appropriation. So just putting some perspective, when you look at the state budget, 19 million is nothing, absolutely nothing. But when you look at the Department of Health's appropriation ask, it's huge.
Right. And when you look at your overall budget proportionately, it's huge. And I think one point that Dr. Edney has made to me, and I 100% agree with him, we need to make sure that the understanding is whatever we ask for is not to come out of the health department budget, but should be added to the health department budget. And we
Right.
don't want, we don't want any unintended consequences that would take away something hugely important, like your work in maternal health, like syphilis issues that are ongoing. There's so many, I know they're there.
Now, I think this work is very worthy of funding.
Absolutely.
And I will advocate for as much as we can possibly get for early intervention, as I advocate for all the needs of public health.
So my question to perhaps Senator Boyd and our other legislators, if we go to you and say that we need $10 million added to the 4 million that is presently in the early intervention budget, what detail do you need to say for that ask? What kind of, obviously we've outlined all the things that we think need to be done. What further detail might you need other than the ask? Please.
Over the past several years, the legislature's enacted $1 billion of tax cuts. They're still being phased in. But as they get phased in, that will be $1 billion a year, every year, in perpetuity, indexed for inflation. It will not be in the general fund because we have cut taxes. It is more likely than not that at the next session, this legislature will abolish the state income tax. It is the #1 item on the agenda of the House of Representatives. They've had Grover Norquist and other wackos down here selling a bill of goods that's the economic equivalent of the flat earth theory, and they're lapping it all up. Every bit of force and power the House of Representatives can bring to bear will be brought to bear to abolish forever the state income tax, 1 some other billion dollars out of the general fund forever indexed for inflation. The head of Medicaid recently retired. In his parting statement, what he said, which you assume is what he is proud that he's accomplished, is how they had managed to hold down the cost of the Medicaid program and how much money the Medicaid program had saved. Well, that's the backdrop we're working against. The people that are bringing about these policies did not seize power through some sort of coup. An election. People voted. People knew very well the policies of the people they put in power. We live in a democracy. Elections have consequences. So I just find much of what we're talking about surreal. I don't know what legislators say they care about. I don't know. All I know is what public policy is being brought about by this body. I will point out I vote no on a lot of stuff.
Thank you, Senator.
I don't know how I follow that. The
You can always say I agree with it. Always. You can't say this. Watch your question.
I think as you're talking to policymakers, we are all passionate about this for a very particular reason. We either see the children, as you do, Dr. Fitz. We have had a child that has been profoundly impacted positively because of early intervention. Or unfortunately, in many cases, you have seen the child that has not had early intervention. And that is the child that keeps us all awake at night. It is the child whose family is tremendously impacted because when this child gets services, the child benefits, the family benefits, their future classmates benefit. They are more able to work in society and do things. They're less dependent on government. This is, as Mississippi State Social Science Research Institute will tell you over and over again, this is your largest ROI on any education program. If you want to talk about saving taxpayer dollars, besides this just being the right thing, this is an opportunity to do it right here, right now, with funding this so that we can properly address these children's needs. These children have these issues by no fault of their own. They have not done anything to create this. No parent has done anything that really creates this. This is the nature of how these children most likely were born in some area. Many of these issues can be remediated, and even the research shows us by the time that many of these children get in school, if they have had this help, they will not even have to have special education services. This is talking about truly putting the money where it is going to have a massive impact. Don't forget that when you're talking to legislators. You're going to go in there with your sheets because you've worked this process, but bring with you the families that can show this, bring with you the school teachers who can tell this, but have that meeting with them. I don't know where I would be today with our family if my child had not had early intervention services. So he is functioning, he is, so I want everybody This helps us as a state. It helps us as a society. This is workforce development. We're going to have hearings on workforce development. Guys, this is the workforce in 18 years. And if we don't do this today and we don't help these kids, this is what all these issues that we talk about that we have in our state, it starts with this, the very earliest. So you all know this, but go with them and tell that story, because you're going to go in with their sheets and we're going to lose some of the impact of what you're saying because you've got your stats and your figures. So tell them why that this matters to them in their district and go in there with this. And this is a very, very small investment when you look at our overall state budget to the impact that it could have. So this is putting, if you say that you are pro-life, this is pro-life.
I agree with everything Senator Boyd said.
Just, if you will, on the task force report, the draft right now, if you'll turn to page 9 and see the importance of investing in EI programs, there are some dollars there about savings in a 2022 study that if Mississippi met the national average of children served by Part C services, Mississippi would save $3,543,000 in special ed costs in 1 year. So back to the budget ask, Dr. Edney, without trying to nail it down too hard, because I know that's difficult. The 19 million, is that 1 year? And would that be repeated cost, or is that 1 year of cost that would drop to later years? Because I know you and I have talked about that before.
Yes, ma'am. I would anticipate that would be upfront cost to get the new model design in place, to restructure what we need to build out what's going to be necessary to make the investment in workforce. And again, I appreciate the hard work everybody has done, but I live in the state government world where onboarding is difficult by state law, that contracting is difficult by state law. There are a lot of things that are just in the way that prohibit us from doing a lot of what you want us to do. Because believe me, I want to do it far more agency wide. As I'm just looking at sustainable funding going forward and just comparing us to Tennessee, Alabama, other states that are doing a better job than we are, that 10 million figure resonates a lot in terms of sustainable year to year, which would mean, at least another 6 million base increase, which I think that's doable. I do think we would need to, with the new model design, we would need to free up some of that direct appropriation to providers to be, towards the whole model design. And, it's getting us to 10 million per year will go a very long way to get us where we need to be. And y'all need to know that I have used some of my discretionary funding this year and can for a little while, but I can't, my discretionary funding is precious and very limited. And I think y'all appreciate the myriad of needs that we have in public health. And Senator Boyd, I would challenge you a little bit. Public health is pro-life. Everything we do is about life. We saved a life today in Mississippi at the Mississippi State Department of Health. We just don't know who it was, but we did it. So this is an incredibly important need among all of my incredibly important needs. And what I would beg you to do is to preach the importance of public health and that this is an integral part of public health. That we care about 0 to 3, but we also care about when they're 6, 7, 10, 12, 18. And I can show you across the board what the ROI is for public health. And we're just not making that investment, Senator Boyd. We are not. And I'm not ashamed to point out the fact that Mississippi is not making the investments that the people in Mississippi need for public health. This is just one small example.
Well, if I
The
can just
budget is,
say,
our budget should, the budget for Alabama is $130 million. And you look at ours. And they're not that much larger than we are, and they don't have nearly the need that we have. It's just being neglected across the board. It's not just early intervention, unfortunately, but we're here about early intervention, and I'm on board to fight for this.
well, I believe the budget for early intervention in Tennessee is about 100 times more than, maybe not quite. Yeah. Yes, I mean, the budget for early intervention in Tennessee is definitely larger than the entire budget for the health department. They have a choice, yeah.
Yeah, in Tennessee, they have a choice to stay with their early intervention providers through age 5 or go to the school district at age 3. We don't have that choice yet. Something to work for.
Yeah. So with that, any comments right now, if we can get back, and I will get with Senator Bryan and Senator Boyd and Robinson and others of our legislators who will help me with some talking points. I would love to have that so that we can all make the resolution that we will go to our legislators and that we will not just do it ourselves, but hand it out to people around us. So I promise you, as your task force chair, that'll be the last task that I do for this task force, is to get something back to you before the end of the year, for sure. But with that said, are there any further comments, concerns, thoughts about this, this draft that we have? I'm pausing for an uncomfortably long time on purpose to make sure everybody has an opportunity. We had. Yeah, I'm sad to say, I don't believe Randy Carter's on. Is that correct? Randy had reached out. She is our family representative, and she had reached out and asked about a friendly amendment to add parent training in as part of training. And I do think that's an important piece. And I see some nods around the room. Could we have someone make a motion, if you will, we'll need to vote on it if we add just a short sentence on family training. I don't think it's going to move the body. That we can put it in, Mary Claire saying, we can put it in the chart of recommendations, if you will. So can I have a, yes, Senator Boyd?
I would move that we include the recommendation to include parent training in our list of recommendations.
Is there a second?
I will second.
Thank you, Ashley. So it's been moved and seconded that we add a sentence about implementing parent training in early intervention also. And so all in favor, do we need to have a roll call on that? No. Okay. A voice vote. If you'll unmute, all in favor?
Aye.
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 Any opposed? Okay, great. That amendment passed. We'll add that prior to the very last recommendations.
Dr. Buttress, this is Sarah.
Yes. Yes, Sarah.
I just wanted to add that we may want to get a point of clarity from Ms. Carter. I know that parent coaching and training is inherent as a service delivery model in all early intervention services for providers, and that again would go to that quality competency training that all providers would offer, but she may be looking for more something in the vein of advocacy support or something else. So Leslie may have more info.
Yes, that Randy and I had talked about this, and what her question or her recommendation was training for parents around their rights within the program and how to resolve disputes was what she was specifically asking about.
So that makes perfect sense. Thank you to both of you for that. And what we can do is just add a blurb about parent training for understanding and their rights for services. Okay. Okay. Dr. Fitz, yes.
Maybe also add parent training and their rights as they transition to the school district for services as well. Because I've that's a place of contention where we.
Yes, that
have
seemed to be a
issues.
consistent problem. If that's all right with everybody, I think we'll just add the sentence to on entry and exit to the program, yeah, and transition. Yes.
Some of this is required of Part C, but has not been implemented as such. Therefore, we do have some language around it, and I actually have my Part C law with me. Got the statute with me.
Perfect.
Yeah.
So
I
okay.
think this is a great recommendation.
Okay, thank you, Dr. Witt. Okay, we will add that and make sure it's part of that. Very important. So now we're moving to the need to vote to approve the Early Intervention Task Force report with the amendment. And so if I could have a motion and a second.
This is Casey. It's really hard to hear if y'all are making motions at the table. So if it hasn't been made, I move that we move forward with the report as presented with the 2 amendments discussed today.
Thank you, Casey. We needed that. Okay.
I'm happy to second.
And Dr. Hannah has seconded the motion to approve the Early Intervention Task Force report with a friendly amendment to add family training, parent training. So all in favor? Designate by saying aye, if you will.
Aye. Aye.
Aye.
Great. Okay.
Aye.
Any opposed? So with that, the Early Intervention Task Force report for 2024 passes. We will have the final report out to everyone with the amendment in maybe a couple of weeks. And it will, I should turn the mic over to Mary Claire, and it will live on the Health Department's website as our other early intervention report says. Senator Boyd.
I want to say from the legislature that convene this task force and do this, our extreme thanks on behalf of the legislature. Just on this committee, not even in the task force report from the prior year, this committee I know has been conservatively, I figured out over 600 man hours of all volunteer time that y'all have done to really look through and create that report. And that is incredible. And we can't thank you enough. But I also want to give a huge personal thanks to the peer staff for their extreme and professional work that they've done on this. And then also to Dr. Buttress, who has dedicated an untold amount of time in making sure that we've got good, solid recommendations on this. And then I want to thank our partners at the health department for really working with us on this to try to get a product that we hope we can move early intervention forward in the state. So to everybody, thank you, thank you, thank you.
Thank you so much, Senator Boyd. But yes, Senator Bryan?
Well, again, I would say I agree with everything Senator Boyd said. But not only with this group and the people who've donated time, one of the assets the legislature has, which is very valuable to us, is people all over the state with all sorts of skills and knowledge and information that in many different ways make this available to us and come and talk to members of the legislature about policy issues and on and on and on. That is an incredible resource that we in the legislature have. And thank you for your efforts here on this committee. And thanks also to your counterparts all over the state who are also donating time and effort in many different areas.
Thank you. Well, Senator Boyd thanked everyone that I needed to thank. I just, first of all, want to say again, thank you so much to this incredible task force. A lot of expertise, a lot of caring, and a lot of dedication. In every single one of our members, I have to say, I've been terribly impressed with everything that everyone has given, a lot of time. I want to thank the peer committee for absolute sure, Ted and your wisdom, Mary Claire, Emily, the number of hours and expertise, and they made it happen. And you can tell by me turning each time, it's kind of the support structure that made this happen for sure. And of course, Dr. Edney and Dr. Witt and your openness and your willingness to hear some tough stuff sometime and to continue to be determined and move forward and work toward making it happen. And that means so, so very much. And probably lastly, need to go back to our senators sitting here who made this task force happen, the last one and this one, and cannot thank you enough for caring about this and helping us move it forward, because we can care all we want, but if we don't have the legislative body supporting us in understanding what is needed and understanding that this is for our future Mississippi. And those of us who are here, probably every single person at this table could be somewhere else, could be in another state, but you're not, because you want to be here. And so I think that's what we all need to keep in mind and know, that we keep doing this and it'll make a difference ultimately. We've moved the needle in some areas. And if you know, I travel a lot, and we were just talking about the fact that nationally people often like to bring up where Mississippi is when we're at the bottom, but they don't remember to show where we are at the top. So I would implore every one of you to be ambassadors for Mississippi and to learn where we really are shining, because there's some spots we are. And I am absolutely certain that soon it will be an early intervention because of the work that happened here. So I want to thank everybody. This was such an honor and pleasure to be here. So with that, any other comments? Do I hear a motion to adjourn? Motion to adjourn has been led. If there's a second, we will adjourn.
Second.
Okay, Dr. Fitz. Thanks so much, everyone, and I hope you have a wonderful Thanksgiving and holiday. So we be